Presenting Dr. Gurunath Parale, a product of prestigious institute, PGI Chandigarh, a pioneering cardiologist with more than 25,000 invasive cardiac procedures like angiography and angioplasty, and 1 lakh non-invasive cardiac procedures like echo stress test. Excellent academician, teacher and speaker at various conferences with more than 40 national and international publications, outstanding clinician and recipient of many fellowships and awards.
I am a office bearer for inviting me for this talk on NSAIDs, non-steroidal anti-inflammatory drugs and heart. Now, these drugs being so frequently prescribed, and we have to know what's their effect on the heart, because many of the patients of cardiac problem have to take these drugs on chronic basis. Now, this must have already been dealt with, the effects of NSAIDs, that is, they are anti-inflammatory, analgesic, antipyretic, and their indications also must have been dealt in detail. Now, this is a huge market as far as US report is concerned, nearly 8 billion market every year, and constituting around 28% of the total drugs prescribed in US. So it's a huge market, so we have to know everything about NSAIDs, its effects on various systems, and some of the systems have already been dealt with. Now, this briefly going to the history of NSAIDs before we go to the NSAIDs proper. The aspirin was the first anti-inflammatory drug. Right from the day of Hippocrates, who described its properties as a painkiller. Then Bayer was the first company to market it as an analgesic. Then in 1981, first time its effect in prevention of heart attack was discovered, and then its effect in reducing mortality to the tune of 25% if it is taken early in heart attack. This was discovered. So aspirin, as we know, is one of the major medicines in the treatment of cardiovascular diseases. So when there were various NSAIDs which have an effect similar to aspirin, they were introduced. So no one knew the disastrous effect that it could have on heart when aspirin has been found to be so useful. Now, NSAIDs, this is a classical, the classification of NSAIDs. The traditional NSAIDs, which was aspirin, diclofenac, indomethacin, ketorolac, ketoprofen, ibuprofen, these have been used for many years. Then the selective COX-2 inhibitors, they were introduced in 1998. These were rofecoxib, etrocoxib, lumericoxib. Now, the basic mechanism must have also been dealt with. Now, basically what it does is interferes with arachidonic acid metabolism, and this arachidonic acid is responsible for generation of thromboxane, prostaglandins and prostacyclin. Thromboxane, as we know, is a platelet aggregant vasoconstrictor, and prostacyclin has exactly opposite effect. Now, there are two enzymes, cyclooxygenase. COX-1, that is cyclooxygenase 1, and COX-2, cyclooxygenase 2. Cyclooxygenase 1 is present throughout the body, and its basic function is housekeeping, that is a maintenance of vascular integrity, maintenance of homeostasis. So it is present ubiquitously in all tissues. So tissue maintenance is the basic effect of COX-1, while COX-2 gets activated in inflammatory states. So its role is in the inflammation, in the inflammatory pathway. So these are the basic two differences between COX-1 and COX-2. Now these drugs and NSAIDs have been classified into different types according to their selectivity of COX inhibition. So you will see the drugs which are on the other side. These drugs are more COX-2 selective. These drugs are more COX-1 selective. So increasingly COX-1 selective, increasingly COX-2 selective. Now these are highly COX-2 selective, nearly 50-fold times COX-2 selective. These are intermediate. So lumericoxib, rofecoxib, etrocoxib, vadlocoxib, they are highly COX-2 selective. These are intermediate. Your nimesulide, commonly diclofenac, they are intermediate. Diclofenac is the least of them. Then aspirin is predominantly COX-1 selective, naproxen is predominantly COX-1. So these are predominantly COX-1 selective. This one has to understand before we go to the different effects. Now, when we are using these drugs, are they really safe? This is the main question. Now, this is an article published in NSAIDS in 1999, deaths because of various reasons. And you will see nearly 16,500 deaths were because of NSAID toxicity. Against maybe leukemia is only on the higher side. Otherwise, all other deaths are less. So, NSAID toxicity is the one which has to be taken seriously. And one of the major contributors of NSAID toxicity is heart. So, one has to know their effects on heart. Now, these are the effects which have been side effects must have been discussed earlier. I won't go into detail. Let's concentrate on cardiac. Now, are COX-2 inhibitors associated with increased cardiovascular risk? That is the question today. Now, this is the first study which was published in NSAIDS 2000, Vigor study. This saw the effect of rofecoxib versus naproxen. And basically, it dealt with the GI events, but also saw at the cardiac events. And now, what were the results? Confirmed cardiac events, rofecoxib 45 and 19 in naproxen. So, more than twice the confirmed cardiac events. Total cardiac events also were more. Cerebral events also were more. So, consistently, rofecoxib did worse compared to naproxen as far as the heart is concerned. Then this is the other study which saw celecoxib versus NSAID. So, this was the Vigor study we saw now, and this is the celecoxib versus NSAID. Now, this looked whether the patients were receiving aspirin and those patients who did not receive aspirin for primary vascular prophylaxis. So, the patients who were receiving aspirin and patients who were not receiving aspirin. The basic purpose was that the actions are similar. So, whether there is a competitive inhibition in COX-1 inhibition and whether there will be interaction of these two drugs, the NSAIDs and aspirin, and the resulting effect, whether it will be beneficial or harmful. Now, when rofecoxib was compared with naproxen, you see the curves bifurcating as early as 2 months. That means the adverse effect of rofecoxib started as early as 2 months after the starting the treatment compared to naproxen. This is compared to naproxen, not placebo. So, it is more than twice harmful compared to naproxen, rofecoxib. Now, celecoxib. Celecoxib, if the patients were receiving aspirin, the difference between celecoxib and other NSAID was marked. That means it negated the effect of aspirin. The events were more in patients who were taking aspirin than the patients who were not taking aspirin. So, naproxen was better, rofecoxib was worse, celecoxib was worse in patients who were taking aspirin. If the patients were not taking aspirin, there was hardly any difference in the events between celecoxib and other NSAID. So, celecoxib should be avoided if the patient is taking aspirin because it counteracts the beneficial effect of aspirin. So, this is according to this trial. Now, there is a risk of myocardial infarction. Now, these same trials and meta-analysis all have consistently shown the risk is very high compared to placebo. Whether it is a rofecoxib, whether it is a celecoxib or any NSAIDs. This can be further corroborated by approved study. Now, this looked at rofecoxib versus placebo, and this looked at directly thrombotic CV events. The first trial looked predominantly at the gastrointestinal effects, and secondary endpoints were cardiovascular. Here, the primary endpoints were cardiovascular, and this was the result. You will see all the cardiac events. The hazard ratio is 2 or more, means 2 to 3 times risk if rofecoxib is given as compared to placebo. So, chances of having a cardiac event is 2 to 3 times higher in the patients who are taking rofecoxib on a chronic basis. Similarly, the cerebrovascular events, also the risk is more than twice. So, all the vascular events are higher in rofecoxib patients who are taking rofecoxib on chronic basis. So, both cardiovascular as well as cerebrovascular events were high. Now, what is the time interval? The the curves bifurcated at 18 months, means the adverse effects of rofecoxib started after 18 months of starting the treatment. So the adverse effect starts after 18 months in the patients who are taking rofecoxib. Similarly, there is increased incidence of heart failure compared to placebo in patients who have rofecoxib, and the curves bifurcate at 6 months. So as early as 6 months, the chances of heart failure increase. Then again, the increase in incidence of heart failure as well as hypertension. So heart failure as well as hypertension, both have been increased. This is probably secondary to sodium water retention, that we will see later. So because of these studies, in 2004, FDA warning came, and it said that public health advisory concerning the use of NSAIDs, including COX-2 selective agents. COX-2 selective agents, that is rofecoxib and celecoxib, may be associated with increased risk of serious cardiovascular events, heart attack and stroke. Long-term use of non-selective NSAIDs, naproxen, may be associated with increase. Here it was slightly ambiguous. They didn't know at that time, but this was definitely found to be harmful, and they deserved to be taken with caution. So there was a worldwide ban in 2005 in rofecoxib. So it was withdrawn from the market. Now came the meta-analysis in 2006. More than 1,45,000 patients, and here the comparison was between COX-2 inhibitor versus a placebo or versus any traditional NSAID. Now again, see the risk. Diclofenac 1.6 times, ibuprofen 1.5 times. Only naproxen fared better. Means naproxen was slightly beneficial compared to placebo as against diclofenac and ibuprofen, only as far as cardiovascular risk is concerned. Now this is again the same study, meta-analysis, different drugs used, so many trials, so many patients, and you will see consistently all were harmful. All COX-2 were harmful, whether it was a vascular event, whether it was a myocardial infarction, consistently on other side of this line. So all were harmful. All COX-2 inhibitors were harmful. Similarly, when it was head-to-head compared with others, again, except naproxen, which was slightly better, all others on this side or slightly on this side. So only naproxen fared better as far as cardiovascular events were concerned. So at that time, in 2007, this American Heart Association came with a stepped-up approach. That means, initially, as an analgesic, start acetaminophen, aspirin, tramadol, or narcotic analgesics. This should be the first line. Then you may go to non-acylated salicylate. Then non-COX-2 selective NSAIDs. Then gradually with some COX-2 activity, and then highly COX-2. So these should be the last ones. At the same time, this choice should depend upon, see the group of patients who you are treating. If it is a high risk, avoid this, go to this. If it is a low risk, then you may try this. So this is a stepped care approach which was advocated by American Heart Association in 2007. Then came meta-analysis of 2013, where 280 trials of NSAID versus placebo, very large number, and another 474 trials of one NSAID versus other. And the main outcomes studied were major vascular events, major coronary events, and upper GI events. So this was a large meta-analysis in 2013. Again, see, all COX inhibitors, the risk ratio was high, whether it was for a vascular event or whether it was for a coronary event. Same was true with diclofenac, same was true with ibuprofen. Only naproxen, the vascular events were less. So if we have to use a drug on chronic basis in a cardiac patient, naproxen is the only drug which may be used. However, your main only with the intention of preventing a cardiac event. It might have certain other actions which may not be as much beneficial. So naproxen is a drug you may have to use when you are considering an anti-analgesic treatment on a long-term basis. Again, the same trial on a graphical basis, fetal, non-fetal MI, it is increased by in COX-8, diclofenac, ibuprofen, and only in naproxen it is less. Now this is another trial which was published in 2014. This is an observational study done over nearly 9 years, a Danish observational study. Again, same findings. For ibuprofen, diclofenac, rofecoxib, celecoxib, and naproxen slightly better for a cardiovascular death or coronary death, but stroke, it may not be useful. That's why I am saying for the other events, naproxen may not have a beneficial effect. But as far as heart is concerned, it might have a beneficial effect. So, consistently, all trials have shown that NSAIDs are hazardous. Now, this Danish study again studied the long-term effects, means whether the adverse effects of NSAID persist for a long time. Now, this adverse now these are the NSAIDs given after MI, and this is the years after MI, myocardial infarction. The highest incidence was in first year, but increase in incidence was maintained even after more than 5 years. So, even on long-term basis, the NSAIDs are harmful after myocardial infarction. So, these are the all trials. Started with Vigor in 2000, class, then meta-analysis in 2001, target, approved, meta-analysis in 2006. All trials, you will see, barring 1 or 2 trials, all have consistently shown there is increased cardiovascular risk for COX-2 inhibitors. And some trials have shown that naproxen might be beneficial. So this one has to know that consistently when one group of drugs are causing increased events, then one have to think twice before using these drugs. Now, when these are similar to aspirin, then why this risk is increased? Because now this is COX-1, COX-2, I told you, COX-1 is predominantly for maintaining body functions and COX-2 is predominantly during inflammation. Now this is the mechanism. Basically COX-1, COX-2, there is a balance of maintaining vasoconstriction, platelet aggregation and arterial modeling, and this balance is disturbed when selectively COX-2 is inhibited and COX-1 is not inhibited. Then this balance is inhibited and you have thromboxane which is generated, which causes vasoconstriction. Prostacyclin which should be generated is less generated and you have more inflammation, and that's why you have myocardial ischemia, infarction and increased coronary events. Similarly, their effect of sodium water retention increases the chances of edema, hypertension, heart failure. So selective COX-2 inhibition and disturbs this balance, and this is again pictorially same thing. How does aspirin help? And COX-2, the balance is disturbed and there is more thrombosis, and which leads to increase in coronary events. Now, so this is proven now. They have increased cardiovascular risk. Now let's go further. Is the risk dose related? Is there a time relation between the risk and starting of the COX inhibitors? And is the association, how should the aspirin association be considered? Now, does the dose matter? What is a high dose? Now, high dose for ibuprofen is more than 1200 milligram, diclofenac more than 100 milligram, naproxen more than 500, celecoxib more than 200, rofecoxib is now out of market. So, let's concentrate on these drugs. Now, this study looked at celecoxib. As the dose increased, the hazard ratio increased from 1.3 to 3.4. But even in therapeutic doses, it was harmful. The risk was 1.3. This one has to understand. If the dose increases, the risk is increased. But even in therapeutic doses, the risk is high compared to the placebo. Now, the different drugs in different, rofecoxib less than 25, more than 25, celecoxib less than 200, more than 200, ibuprofen less than 200, more than. So, different doses, consistently you will see the risk is high. Consistently for any drug, except naproxen, the dose of less than 500 milligram, it might be beneficial. But if the naproxen dose is more than 500 milligram, that benefit goes and you have an increased risk. So this risk is more for death, more for heart failure as well as for infarction. Consistently, whatever the dose you take, the risk is high, but the higher the dose, more the risk. Now this is a patient of heart failure and different doses. Again, increase in dose, increase in the risk. Increase in dose, increase in the risk. So even if the dose is less, the risk is there, but if the dose increases, there increase incidence of heart failure. Similarly, increase in incidence of myocardial infarction. Higher the dose, higher the risk, and increasing the incidence of death. So the dose does matter. If you have to give them these drugs, give in the minimal possible dose. That's the message. Now what is the time? Now this drug, the drug here used is a celecoxib versus placebo. Low dose celecoxib, high dose celecoxib versus the placebo. Now versus the placebo, as early as 6 months the curves are starting bifurcating. So the events have occurred as early as 6 months. And the dose, when the higher dose is used compared to lower dose, the curves bifurcate at the age of somewhere around 15 months. And when the dose is low compared to placebo in this trial, the curve bifurcation is 20 months. So somewhere between 6 months, the harmful effects of this drug start and may be higher after the 18 months. Now, certain other trials, especially one trial, looked at NSAIDs post-CABG patients, and here it was found that adverse effect was noted even in first 7 days. 0 to 7 days you have a high cardiac event. So NSAIDs, especially COX-2 inhibitors, should be strictly avoided post-CABGs because you can have an adverse effect in as early as 7 days. So you have these all NSAIDs, then rofecoxib, consistently all drugs, there is some increase in risk even in first week of starting NSAIDs. So they are as dangerous drugs and they should not be taken lightly, and we have a tendency to prescribe them slightly loosely. Now, effect of aspirin, their interaction with aspirin. Now aspirin, as we know, has been consistently shown in various trials is definitely a useful cardioprotective drug. There is no doubt about it. Now its effect is basically because the COX-1 inhibition, because it irreversibly binds COX-1 and inhibits platelets for its lifetime, that is 8 to 11 days. Till the time platelets are alive, they are inhibited. So it's an irreversible inhibition. These other drugs, they have a reversible inhibition. That is the difference between the action of these two. This is irreversible and this is reversible. And aspirin also acetylates COX-2. That's why it has anti-inflammatory role. So it inhibits COX-1, acetylates COX-2. So it has an anti-inflammatory role. Now, this is an interesting study. If ibuprofen is given before aspirin, especially up to 2 hours before aspirin, then it negates the effects of aspirin, because it reversibly binds platelets and aspirin doesn't have receptors to bind platelets. So aspirin doesn't act. So the chances of increasing cardiac events, if ibuprofen is given concurrently with aspirin, they are more. So ibuprofen and aspirin combination should be avoided. So this was a thromboxane inhibition and its translation into platelet aggregation. That platelet aggregation also is prevented if ibuprofen is given before aspirin. But this does not hold true for rofecoxib or celecoxib. So only with ibuprofen, then that risk is there. So we have seen risk with cardiovascular events, we have seen risk of heart failure. Now hypertension. All the NSAIDs, they increase the blood pressure, and the effect seems dose dependent and probably involves inhibition of cyclooxygenase 2. And this is presumably reducing sodium excretion and increasing intravascular volume. Probably this must have been dealt with by Dr. Kiran Joshi, so I won't go into detail. But they have a tendency to increase incidence of hypertension. Another thing, some studies have shown potential of NSAID to antagonize most of the antihypertensive treatments. So not only they increase incidence of hypertension, but antihypertensive effect is also reduced, except of calcium channel blockers. Especially ACE inhibitors, antihypertensive effect is reduced by NSAIDs. And calcium channel blockers are relatively safe as antihypertensive if you are using NSAIDs with them. This is one study of lumicoxib where it was shown that BP is increased by NSAIDs. Heart failure risk, we have seen there is increased incidence of heart failure. Now this is, I talked to you about the study post-CABG, where valdecoxib and parecoxib were used, and the risk ratio was more than 3 times 3 times the increase in incidence of cardiac events if the NSAIDs are given after CABG for analgesic action. So 3.7 times risk of a vascular event. So what's the conclusion? Benefits versus risk NSAIDs. Now these are the FDA recommendations in 2014. NSAID medicines may increase the chance of a heart attack or a stroke that can lead to death. This chance increases with increasing doses of NSAID medicines, with longer use of NSAID medicines in people who have heart disease. NSAID medicines should not be used right before after heart surgery, that is after CABG. It should not be used. NSAID medicine should only be used exactly as prescribed at the lowest dose and for shortest time needed. And these are 2015 recommendations, summary of ACC, American College of Cardiology, American Heart Association. This is a summary. All discourage use of all NSAIDs in patients with chronic heart failure. All recommend against use of NSAIDs, particularly COX-2 inhibitors in patients with established cardiovascular disease. All recommend NSAIDs be avoided in patients taking aspirin for cardioprotective benefit. If treatment becomes necessary in this patient population, ibuprofen should be avoided. We have seen. Other NSAID, we don't have sufficient data. If the patient is at moderate to high risk of potential cardiovascular event and treatment becomes necessary, then initial management should be attempted with acetaminophen and then naproxen. Thank you.